We are super excited today to have one of my friends, Dr. Michael Steinhaus, who is a true innovator and revolutionizing the spine surgical world. He focuses on minimally invasive surgeries and really revolutionizing the industry in this area. Back pain is one of the biggest issues in healthcare. 80% of people in their lifetime will have back pain at one time or another.
I basically tell patients, if you're human, you're going to have back pain at some point in your life. You know, it's as close to 100% as we can get. I tell my patients this, who I see for the first time, getting a second opinion is a great idea. If you're having spine surgery, it's a really important decision in your life, and make sure that the opinions line up.
But if we don't marry the symptoms with the clinical findings, you can really put yourself in a bad situation. Welcome to the Healthcare Revolution podcast. We are super excited today to have one of my friends, Dr. Michael Steinhaus, who is a true innovator and revolutionizing the spine surgical world. And he focuses on minimally invasive surgeries and really revolutionizing the industry in this area. And super excited to have him on. Before I introduce him, this topic is super important because back pain is one of the biggest issues in healthcare. The most amount of dollars go to spine issues, to low back pain. 80% of people in their lifetime will have back pain at one time or another. This is something all of us deal with, our families deal with. This is something that's really important, and he is an absolute expert, one of the best in the nation, I would argue, that has just really taken this profession and taken it to a new level. His training is so specific in spine, and we're so fortunate to have him here. So I met Dr. Steinhaus years ago when we opened our first clinic. I had a case, a spinal fracture that was poorly managed in the ER that ended up just walking into my clinic, and I was unsure if the fracture was stable or unstable, not really sure what was happening, and Dr. Steinhaus had walked into my clinic just to get to know me, and we pulled up her imaging and right on the spot with her there, and we were able to determine that it was appropriate to actually start therapy. And he's just been a huge help from the beginning, and just so grateful for all he does for the community. He has raving fans all across Utah, and he just does such a good job. And his bedside manner is just next level. It's rare to find a surgeon that has everything like this.
Oh.
So
Thank you.
welcome to the podcast.
Thank you for having me.
Yeah.
Excited to be here.
I want to give a little bit more background to Dr. Steinhaus. So he's board certified spine surgeon, specializing obviously in minimally invasive and robotic spine surgery with a focus on motion preservation. That's important because if you fuse a certain area, the adjacent segments, meaning above and below, can be compromised. So he focused on disc replacements that can really keep that motion preserved. And then he also wants to restore function and improve quality of life for people. He's completed advanced fellowship training in spine surgery and has contributed research and education within the field, staying closely aligned with the latest innovations and evidence-based practices. His approach blends surgical precision with strong emphasis on patient education, ensuring individuals fully understand their condition and treatment option. So again, Dr. Steinhaus, such a pleasure to have you here.
Again, thanks for having me. I'm so excited to be here.
Yeah. Tell me first, what is really the prevalence of back pain? I gave a little bit of insight, but what is the prevalence of back pain across the nation in your experience?
Oh, I basically tell patients, if you're human, you're going to have back pain at some point in your life. You know, it's as close to 100% as we can get. So I think, 80 to 90% for sure, patients have some kind of extended period of low back or neck pain. So it's just part of the human condition, I think.
Yeah, absolutely. And back pain is just a normal symptom. It's like, getting a cold. We're all going to have it at some point for the most part. And most of the time you did too much too soon after doing too little for too long. And sometimes you pushed it too hard and you injured it. And sometimes you didn't push it hard enough and you injured it,
That's right.
So we're going to mostly what we're going to talk today is the things, back pain that has failed conservative care. You've maybe tried doing things on your own. Maybe you've YouTubed some things. You've done some exercises. Maybe you did a formal plan of care in physical therapy or with chiropractic. You've done maybe injections. You've done all kind of exhausted all conservative things. And now you're in the right space. You're meeting with Dr. Steinhaus, and he's giving you options. And that's really the discussion today. But before we dive into that, tell me what really got you into spinal care, and why is it such a passion for you?
That's a good question. Actually, it's kind of a funny story. You know, in residency, you go through all these different specialties, and you have 5 years basically in residency to decide what specialty you want to focus on for the rest of your career. So in my first 3 years of residency, if you'd ask me that question, I would say, I'm not sure exactly what I want to do, but I know that I don't want to do spine. And the main reason for that is...
That's funny.
I tell that story all the time. The main reason for that is I'd only been exposed to kind of the traditional spine surgery that people hear about and that they have nightmares about, you know, the big open, take all the muscle down, blood loss, long hospital stay, long recovery kind of surgeries. And it just wasn't for me. And I would say, so my third year of residency, one of the kind of leading innovators in minimally invasive spine surgery in the country, I just got super lucky, and he showed up at our institution as one of my new attendings to work with. And so the second I started shadowing him and saw what he did in the OR, and most importantly, saw his patients after surgery, I was hooked. I couldn't, so then I totally did a 180 from anything but spine to only spine. And the reason is, seeing his patients post-operatively, in the hospital, most often going home the same day, sometimes they stay overnight, but just seeing the dramatic transformative difference in these kind of minimally invasive techniques versus the traditional techniques showed me that this is where spine surgery was going to go, and it was going to transform the way we do spine care. And so that was something that, seeing firsthand in the hospital, that I decided that moment, like, this is what I want to do, and this is what I want to be a part of over the next, 20, 30 years.
Yeah. Tell me, for someone that doesn't know what minimally invasive spinal surgeries are versus traditional, to help us understand both categories here?
Yeah, so traditional spine surgery, and there's a place for this, still here. We're not saying that, never get traditional spine surgery, but it involves usually a big incision, open incision, where you're exposing the back and exposing the bone and all of the neural elements to the outside world. And to get down there, you're having to take the muscle off the spine, stripping the muscle off the spine, and again, exposing this big kind of wide exposure, which carries with it a number of challenges and complications that are limited with these kind of more minimally invasive approaches.
And we're talking pulling muscle back, cutting through multiple structures, taking away bone, right? Kind of getting all the structures that are covering the spinal cord off, and then opening things up. So that's traditional.
That's traditional, and the reason it's done that way, and it has been done that way forever, is because, this is a very delicate thing. The spinal cord and the nerves are very delicate. So you want to be very careful around those structures. And so you really, traditionally, before we had the advent of this technology, you really want to see everything that you're doing so that you know that you're not injuring anything, and that you are where you think you are, to avoid, really catastrophic complications. So I think that's why it had been done that way. Now, with new technology and this kind of minimally invasive approaches, we have ways to get down to the spine. We have ways, I tell patients it's like having a GPS. Before we didn't have a GPS. We'd have paper maps. We have to open up the whole thing. Okay, here's this bone, here's this bone, here's this nerve, here's that nerve. Now, because we have a GPS, we can go to that spot without having to open up the spine in a big way. So instead of making a big incision, we make an incision the size of a fingernail, and we get to go down there, and we can see exactly where we are. We have several ways to confirm we're in the right area, and do the exact same work that we would be doing with a big open incision, but through smaller incisions. That just means, patients go home from the hospital sooner, less blood loss, less infection risk, faster recovery, and most importantly, returning to doing the things that they want to do much faster.
Yeah. You think about how important that is. With traditional, you think about they're in the hospital for a while, they're down for the count, they can't return back to work, right? We cut through multiple structures, the body gets inflamed, the body gets irritated, right? It just sets things way back. But with this robotic surgery, minimally invasive, you're going in from this tiny incision with these cameras and tools, and doing very similar, if not the exact same surgeries with not having to cut through all these structures. It's huge.
Yeah, it is. And I think, and again, that's exactly that. Seeing that difference is what kind of made me go into this, I think. And you know this better than anyone, cutting through the spinal extensors and muscles, and, you know, they kind of can scar in, but they're never back to what they once were. And I think, you know, then a patient's left with that for the rest of their lives. So I think the muscles are rarely the problem that we're going after in spine surgery. And so I never saw the benefit of taking them off the spine or doing something we don't need to do, causing collateral damage we don't need to cause.
For the listeners that don't really know the training, the extensive training that it takes to master the skill of doing these surgeries, give us just back of the book summary of what it's like and the level of effort and time and dedication it takes and precision to be able to do what you do.
Oh, you know, it's years and years of training and seeing these surgeries over and over and over. I think like by the end of my residency, I'd seen 2,500 cases, and then fellowship, we do another close to 1,000, you know, so you do a lot of work before you know, are off on your own doing this on your own. So, which I think is, you know, even though that sounds like a long time, and it is, I think it's very good for patients because then they can feel confident that, you know, by the time you're there and you're the doctor they're seeing, that you know what you're doing, you know. So so it's a lot of reps of seeing the same structure a million different times and staying safe. And
break down a surgery for us and the tools that you use to be able to go in and do these types of surgeries. Let's just say a disc replacement.
Yeah.
What is it? What are the tools that you're using? And talk to me about the precision of what it takes to do a disc replacement.
So a disc replacement, you know, we're either working in the neck or in the low back. And so with a disc replacement, we're coming from the front side. So in the neck, we're making an incision in the front of the neck. And we're basically, you know, same thing in the lumbar spine. We're, you know, kind of in a simple sense, we're pushing all the important stuff aside. We don't have to cut any muscle, which is really nice about those approaches. We make an incision in the skin and then push either your abdominal contents or the contents in your neck aside to get right down to the spine. Then you're directly visualizing the spine, usually through the use of a microscope or some kind of magnification lens, so that you can kind of see exactly what you're doing around the nerves and around the spinal cord. And then we have these kind of microscopic, minimally invasive tools to remove what's left of the disc and make sure that we're clearing, you know, any pressure off the nerves that we can and off the spinal cord. And then we have these special trials to get the perfect size for patients, right? So every patient's a little bit different size of their, you know, disc space, size of their vertebral body, bone quality, all that stuff.
Help us understand how you get the disc out of that space and when you're using such small tools. So, because I've been in surgeries, they use the little chompers.
Yeah, the chompers.
I forget the tool, what it's called. What is it called?
Pituitary is a chomper.
They're just
or a
like,
Kerrison,
They just like sit there and chomp at it and just get chunks out. But they have the benefit of suction.
Yeah.
So how do you get the disc out to get the disc replacement in?
So the disc, so the chompers are the Kerrison rongeurs, or there's pituitary rongeurs, are just fancy words for chompers, right? So we're just picking it away. And then there's, you know, these tools we call curettes that kind of scrape the bone, the remaining disc off the bone, so that what we want is to be left with no disc in there and just your bone. So once we scrape all of the bone off all the disc off and pull it out, we're left with basically just the bony edges. And then that's when, you know, the work begins of getting the correct size implant and
I love it.
Stuff in.
That is absolutely incredible to me. And just the level of, I'm just thinking about what you're viewing through a camera. If you've ever watched the Magic School Bus, it's not like the Magic School Bus. A lot of people probably, you know, as you're listening, you're probably thinking like, oh yeah, like the bus kind of going through the different intestines and pushing abdominal things aside. Tell us what your visual looks like as you're going through these different tissues. Does it look like Magic School Bus?
A little bit, you know. It's so we're through a microscope, so everything, like every little movement is magnified by times 10, you know, and so you're looking at you know, these structures which really aren't so big but very close up, so they appear to you very large, and it just allows you to make kind of micro motions to make sure you're staying as safe as possible and getting every little ounce of any compression off the nerve. So you can, what I like to do is to make sure that I'm seeing, let's say a disc replacement in your neck, we're seeing your spinal cord fully. We're seeing both nerves at that level totally open and free of any compression. So to do that, you really want to be magnified down. So your tools are, appear very big in your field of view. So we're looking with this really fancy microscope down that kind of just magnifies the whole space. So it's a space that's probably the size, not even 2 centimeters, but it feels like it fills a whole, big screen TV width. So so that part's fun.
That's awesome. I love it. So tell us what patients get wrong when they're thinking about back surgery. Like, what are some common misconceptions that you have regular conversations about as people come into your clinic?
So I would say, there's a lot out there about back surgery, and there's a lot of different types of back surgeries to get, right? So I think the biggest wrong is trying to kind of bucket everything into one bucket and say all spine surgery is the same.
I got my neighbor got a back surgery and it didn't go well, therefore it's not going to go well for me.
Exactly. And and certainly there's surgery, surgery doesn't always fix the problem. And I think the key for me is that you want everything to kind of line up, right? You want the patient's complaint or their symptoms to line up with what we see on the imaging, and have the imaging and that complaint line up to say, this is something that we can take care of. And that's not always true. And so I think what I like to do with my patients is really take the time and do a bunch of homework before surgery. So much of surgery is planning. And so if you make the right plan for the right patient, then people do really well. And so I think that's the key, is not all spine surgeries are the same, and not every problem needs a spine surgery. And so I think, of course, just like with anything, some surgeries are done that may not need to get done, or the wrong surgery was done for the wrong problem. And I think if those don't line up well, that's when patients don't do well. So I think that's one kind of myth, is that all spine surgery is the same, and thinking of it that way. And kind of, as you mentioned at the beginning, I'm very much a motion preservation and minimalist in terms of the surgeries that people need. Nothing makes me happier than to see, a patient who's coming for a second opinion who said they needed a 10-level spine fusion, and we get to say, I think you just need a decompression, which just means to take pressure off the nerves at one level, and patients do really well. And I mean, there's nothing that makes me more excited to save a patient from having fusing half their spine. So I think that's the key too, is I tell my patients this, who I see for the first time, getting a second opinion is a great idea. If you're having spine surgery, it's a really important decision in your life, and make sure that the opinions line up. Yeah.
I think I really want to emphasize what's a point that you made that I think everyone needs to know, and that is that your symptoms need to align with what we see in both testing and imaging. If there's not alignment between those things, sometimes what you see on the image is not really the problem. And it's super important that if you have an MRI and you do have back pain, that we know that there's that alignment there. Because you could get a surgery that's saying at a certain level, maybe L4, but as you do the tests, the symptoms are coming from L5. And if there's not that alignment, it doesn't mean that the L4 is the issue. Sometimes you can have stuff like a bulging disc at certain areas and not have any symptoms at all. But if we don't marry the symptoms with the clinical findings, you can really put yourself in a bad situation. Yeah. And, I think all of us are guilty. We all try to do our best in our field, and sometimes we operate and make the wrong decision.
Sure.
And patients don't get better, right? And it's super important. All of us are working together to make sure we're aligned on those things.
100%, yeah.
Tell us, what are common fears that people have as they come into your clinic? What are you hoping to kind of abolish as far as the fear route as people talk to you?
I think, people, and rightly so, if you're having spine surgery like we talked about, it's a big decision, right? And I think spine surgery by definition is doing surgery around very important structures, right? So people are always, the number of times I get asked, like, am I going to be paralyzed from this? Again, very, right concern, because we're operating around those things. Now, I think the thing to know is this is our everyday, right? So I work around these things all the time, and we keep them safe, right? So while that risk is there, it's kind of infinitesimal. It's tiny, and I think that's one fear that, I haven't seen before, but right for patients to worry about that. Other things that I hear commonly are, once you start having spine surgery, it doesn't stop, so you have the next level and the next level and the next level. And a lot of that is to a point I think you made before, which is if you don't need a fusion, don't do it, and I think there are times when we need to do a fusion and to give the spine stability in cases where there's instability of the spine. So there's a place for it, but don't do it if you don't need to, and do the least amount that you need. I mean, I think that's the key is, again, kind of all of this minimally invasive mindset, which is not only with the surgery are we kind of causing less collateral damage to the muscles and the soft tissues, all of which can cause progression at other levels and cause kind of side effects on their own. It's also, okay, we don't need to operate on every little every little imaging finding that we see. So I like to tell patients that we don't treat MRIs just like you were alluding to, we treat you, right? So we have patients who come into our office in a panic that they see severe, 27 times on their MRI report, and we have to kind of calm them down and say, if I MRI everybody on the street, we're going to see a lot of this pathology or severe degeneration, these words on the MRI that don't mean anything if you're not feeling those symptoms.
Yeah, I think that's super important to know for sure. Tell me, what is the difference for people that maybe are pursuing a surgery? What's the difference between a microdiscectomy, a disc replacement, and a fusion? And what are some things people should consider when getting each one of those?
Yeah, great question. So a microdiscectomy usually is done when you have a disc herniation. A lot of people describe, I had a pop in my back. I was doing fine. I felt a pop in my back, severe pain going down my leg or down my arm. And the MRI will show, a fragment of the disc that's kind of popped out and is sitting on compressing the nerve. And so in those cases, we think about doing, I would describe maybe our smallest operations, a microdiscectomy, where we basically, the idea is you're going in to kind of pluck out that piece of disc that's in the wrong place or sitting on the nerve.
And with that one, are you cutting through any muscle, or it's still minimally invasive?
Still minimally invasive, yes. So we're just kind of pushing the muscle aside for the half hour of the procedure, and then we kind of take our tools out, and all the muscle kind of falls.
Is there traditional microdiscectomies and minimally invasive microdiscectomies?
Yeah, so a more open microdiscectomy again can involve taking the muscle off the spine and getting exposure at that one level. Still relatively small incision, but doing something either tubular microdiscectomy or an endoscopic microdiscectomy certainly doesn't involve taking the muscle off in the same way. So again, pushing the muscle aside for that moment of surgery and then, pulling your tools out.
Is there ever cases with microdiscectomies where they have to remove part of the bone? So in our world, the spinous process or the lamina, portions of the vertebra.
Yeah, so occasionally we'll have to move a little bit, and that only would occur if the portion of disc is sitting in a place that's like under a piece of bone, and you can't get there unless you have to shave a
but that's more
or two
rare
of bone.
To have those.
Yeah, rare.
Okay.
Yeah. So then a disc replacement is, let's say, in the neck, oftentimes we're doing disc replacement in a situation where the disc herniation is broad enough that it's hitting the spinal cord. So in the neck, it's a little bit different than in the low back. The low back, we're able to come from the back and retract on the nerves to see where the disc sits in the front of your body, where the nerves are right behind the disc.
Yeah.
So in the back, we can safely retract on the nerves to get to a disc fragment. So we are really commonly doing microdiscectomies in the low back. The problem in the neck is your spinal cord doesn't tolerate us pulling on it. So so we can do microdiscectomies in the neck, and we do. They're just a little bit less common because they need to be in a position where we're not going to have to retract on your spinal cord, which is why oftentimes we're coming from the front side to take the disc out from the front rather than coming from the back. And so when we do that, we take the disc out from the front to get that fragment that's pushing on your spinal cord. That's when we would replace it with a disc replacement. In the low back,
the disc replacements, they don't reduce any motion. Right, like a fusion does.
Right. The idea is that keep your motion, right?
So it's almost as if it's similar to your current disc. Is that correct?
Yeah, that's the concept, right? That's the idea.
And then, do you see limited motion with scar tissue and things like that after the disc replacement? What do things look like after?
We don't tend to. No, once you've healed from the disc replacement, people tend to report similar range of motion.
Great. With those disc replacement, do you suggest people go to PT after that? What's kind of the rehab look like after disc replacement?
Absolutely. So I think physical therapy is key. I mean, anytime you have any, disc herniation or something sitting on a nerve, we think that, your body does so much compensating to deal with it. I mean, mostly because oftentimes when you have surgery, you've already been spending months doing the non-operative route to try to get it better before surgery. So by the time they come to us, it's been months of altered body mechanics, nerve compression, which can cause atrophy of muscles, and all of these kind of compensating that the body does. So I recommend that everyone is doing physical therapy both before and after these surgeries, both to get
What does the rehab look like after? And let's actually, why don't we go to fusions, and then let's talk about like the rehab of microdiscectomies. That way we won't get lost here. Go back to fusions for me.
So fusion we do, there's a couple reasons to need a fusion. One would be, and most commonly would be instability of the spine. So either like a fracture causing instability, or over time with degeneration of tissues, a level can get kind of lax, and you'll see this is where your doctor will point out one bone is out of place compared to another. They may use the term spondylolisthesis, just a fancy Latin word for
different
slippage.
Than what a chiropractor would tell a patient of your spine's out of alignment.
Yeah, right. Yeah, and they have X-rays too, oftentimes, and you can see that in the either with physical therapy or with chiropractor as well, but not the same. Yeah, the same. That terminology may not mean the same thing, but it can be obvious on the X-ray to see one bone kind of out of place with another.
Do you typically get a flexion extension view just to check that instability as well?
I do. And oftentimes, because even a little bit of slippage can be expected, and those patients don't, our data shows that those patients don't tend to need fusion. So really common to have what we call a grade 1 slippage. And I think that's a good case, where sometimes patients are getting fusions that may not need to. And I think, where we would think about doing just a decompression alone in those cases. But the flexion extension views, as you mentioned, are important to understand. The spine is dynamic, right? And so if we get one slice in time, whether it's an X-ray or an MRI, we don't see what happens when it moves. So that's when we have patients flex forward and extend back, we can see if there's some what we call dynamic instability, or if that bone is really moving all over the place on those pictures. Then we may say, okay, maybe they're a better candidate to get some stability, which lends us to think about fusion.
Yeah, I love it. Okay, now walk us through what happens. What should people expect after each one of these surgeries?
So microdisc, again, kind of our smallest operation, and honestly, people usually wake up from that surgery and are, the pain is gone, which is like my favorite surgery to do because, So, really small incision.
I want to make
healing.
a quick comment here.
Yes, please.
I had a patient that I worked with 2 cases throughout 2 years.
Okay.
He was a carpenter. Okay. And he did high-end carpentry, finish work. Does a lot of the Pareto homes here in Utah. Just a really cool dude. But we'd get him out of back pain. And then he'd go like 6 months. And then it would just come back. And it would be weird things. Like I picked up literally like a drill battery off the ground. Like really dumb things. Right. We ended up getting him into surgery for this. I found through the surgery, the disc was trapped in a place called the axilla. I didn't know what that was until the surgery. So essentially it was trapped between 2 structures. Mm-hmm. And we can agree that a lot of discs reabsorb, right? They can bulge, they can herniate, but the body can reabsorb them. And every surgeon I've talked to is like, yep, that's very true. That can happen, right? But with this case, it got stuck between this exit point, and it was trapped. Mm-hmm. And there was no way for it to come back. And it was so eye-opening for me because I thought as a PT, I couldn't do my job, like all these stories we tell ourselves. But ultimately, I couldn't fix that because it was not fixable. Right. It needed surgical intervention. So I really want everyone to understand, like, when you've done your due diligence in conservative therapy, it's not that it's sometimes maybe lack of care or quality of care, but I think we got to appreciate that when we exhaust all of our efforts, it's okay to get these surgeries. Mm-hmm. That's what they're there for. Right. And back to you with this microdiscectomy, people get immediate relief because that disc has been pushing on those nerves, and nerves don't like small spaces. They don't like pressure. Yeah, they don't like stretch.
Yeah, they don't.
So when they do have that, it just irritates things. Yeah. So keep going.
No, yeah. So yeah, usually patients wake up and they're floored because the pain is gone.
Do they call you Jesus? They're like,
I haven't gotten that yet. So honestly,
miracle worker.
the hardest
Absolutely.
the hardest part about those is when they feel so good. I tell patients before surgery, I'm like, you're going to feel so good that you're going to want to just go back to normal right away. And so the biggest risk of those surgeries is as that disc heals in, we don't want more of the, we want to take out as little, kind of in the minimally invasive approach, we want to take as little disc of yours as possible.
And why is that important?
Well, the herniated part wants to come out. The rest of your normal disc, we want to keep as much as possible.
Tell us what herniation means.
So the herniation, so that's the part that kind of pops out that's causing all of your symptoms, right? So, and unfortunately,
is it truly like jelly?
Yes, it's
like when
jelly.
people like a jelly donut.
It's
it
a
like
jelly donut? It's funny. People
talk about that, but is it really the consistency of jelly? Is it tougher?
It's crab meat. Is what it is.
Every surgeon I've talked to, and I've actually felt it.
Yeah.
It's like resilient tissue.
Yeah. Oh yeah.
And it's really tough, but it really is like crab meat.
It's crab meat. Yeah, it's the closest thing we can think to.
And that's the part, the nucleus pulposus was like the center of the disc that kind of bulges out of the harder part of the disc.
That's exactly right. So when I talk about herniation, that's what we're talking about. And so with that surgery, we're just taking the part that's in the wrong place out. And we want to leave the rest of your normal disc as much as possible because the more we take, the less disc you have for the rest of your life, right? But that means while this disc is healing in, you are at some risk for the first little while as it's kind of healing and scarring in of having more of that disc come out. So the main recovery period, I think, is for the first month or so. And we tell patients don't do any big heavy, the things that stress the disc most are axial load, which would be like heavy lifting, and torsion, so twisting. And big bending of the back. So, things like golf and tennis.
So if you're moving, this is not a good surgery.
Not a good time, or get some movers, So that's why I tell.
Get a lemonade and just watch.
And then, but those patients can start some kind of lighter PT as soon as they're ready. I tell them a week or two after surgery, get back in with your therapist and get started light, but kind of gradually build up. And I think by 6 weeks, they're like, relatively good to go.
I love that philosophy of the communication to the patient of light therapy because, a lot of surgeons will say no therapy because they're fearful that the therapist might push them too hard. But the best indicator you're giving is the patient tells the therapist light therapy. Every PT knows light therapy, right? What's hard is when our surgeons say no therapy for 6 weeks. We think about the level of atrophy, the level of scar tissue, like the level of compensation changes. Like there's just so many things. They just become fearful. There's only so much you can educate to, and they just kind of make up the rest of the story. Yeah. And you might educate on 15 things, they remember 2.
Right.
But it allows us to jump in early on and say, let's add a clarification to what Dr. Steinhaus was saying. Yeah. He didn't mean that don't move at all.
Right.
He means be gentle.
Right.
Watch for your symptoms.
Right.
He means that you can lean forward and hinge at the hips. We just don't want you loading the spine and bending and touching your toes 100 times. Right? We need blood flow. Yeah. But it doesn't mean stay in bed. Right. And some of the interpretations that patients get sometimes just blows my mind because I'm like, that is not what they said.
Totally.
And if we do feel like that's what they said, we're going to jump on a phone call with them to clarify because based on my experience with this surgery, that is not what they mean. Right. So it allows us to jump in there.
Right. And I think that, again, the minimally invasive approaches allow us to kind of challenge the old dogma of therapy after spine surgery and, how long recovery needs to be. Because if we're not removing muscle tissue off the spine, we don't need that to kind of heal back and scar in. Then it means we can get patients much faster back to physical therapy and to recovery. So I think that's a huge benefit. So I tell patients basically as soon as you feel ready is when you can, people ask, do I need to be off for 3 months? Or I saw another surgeon, they said it's going to be a 6-month, sitting in bed and no physical therapy. And I say, no, as soon as you feel ready, we should have you back and moving.
What about return back to work and what's their expectation to return back to activity?
Again, I think I use a symptom-driven kind of approach, which is, if they're feeling okay. I have patients who have microdiscectomies on a Friday and go back on Monday. I had a crazy patient who had surgery on a Friday morning and was back at work that afternoon. So I think you can go back, and I'm not recommending that necessarily. Yeah, exactly. Not recommending that necessarily, but it just means I think, that it's kind of what we were talking about before. A spine surgery is not a spine surgery. Is not a spine surgery. I think they're very different types of surgeries, and whether you need, bone to fuse to a device is very different than, someone's soft tissues healing after a small microdiscectomy surgery.
Yeah.
So.
I love it. Okay, tell me about the other ones. So with disc replacement, what should we expect after surgery?
So disc replacement, just a little bit more, tenderness from us opening that space back up. Oftentimes the pain is because we're not cutting muscle. Most of the pain, almost by definition, if we're doing a disc replacement, some of that disc has collapsed. And so the body gets used to.
You lose a little bit of that volume.
You've lost a little bit of volume. You lose a little bit of height.
Do people get shorter?
People get shorter. So that's why, people are older and they've lost 3 inches. Usually I say, look to your disc spaces across your spine, because usually that's where it comes from. So because they've lost some height, when we put that space, we put the disc replacement device in there, we try to get them back to their normal native height. And so
normal as in 10 years ago, or normal as in where they currently are?
Well, it's a good question. And so what we try to do is match the adjacent levels. So we don't try to over distract. It's a kind of a good Goldilocks moment of, you don't want to do too short, because you want to make sure there's space for the nerves and give them something that's physiologic, but you don't want to over distract. And so that's where the trialing and the in surgery comes into play, where we're putting spacers in and finding the right one at that right time. But so because of that, you have some stretch type muscle pain and maybe some stretch type nerve symptoms can occur because of the nerves, because of the stretch in the OR. And I would say that's closer, rather than a day or two of feeling like you had surgery. That's a couple weeks of feeling like, okay, I had, surgery and my tissues were stretched. But just like with microdiscectomy, with those patients, we have to get back to therapy after a few weeks and get started.
And what is the collaborative rehab look like for disc replacements?
So, I'm huge about, the collaboration with physical therapy and getting them back. And I usually, mostly because I think the therapists are much smarter than I am in this way. I think, using them as kind of the guide. Here's a patient who just had surgery. I think it's safe for them to get back to therapy, quote, light therapy first, but kind of slowly building up, and using the therapist's expert knowledge more than mine to know how quickly to progress them. I think is kind of the way I do it. But I think that means, just like you're talking about, which I think is really what we need to be doing, is collaborating, texting and calling and saying, okay, this patient's now this far out. Is it okay to do this? And
what are cases? What are examples of cases that you've had that are like, that was really important to collaborate between different providers?
Oh my gosh. I know
you got dozens,
all the time, like dozens. I had one recently where a therapist was seeing a patient, hadn't even had an MRI yet, but he said, I'm just suspicious based on these symptoms. This person has bad spinal cord compression in their neck. They have, symptoms and signs of what's called myelopathy with, both arms were starting to go numb, and my handwriting was a little bit off, and my balance was a little bit off, and all of these things the therapist put together and said, this person doesn't have an x-ray, doesn't have any imaging of their neck, but has been progressing relatively quickly. Can you get them in just to see? Because I'm suspicious there might be something going on. And sure enough, we get an MRI, and it's like the biggest disc herniation I've seen sitting right on the spinal cord. And that's the kind of thing where it's like, if that therapist hadn't A, picked up on it, and B, reached out, that patient could sit around for a long time and have some progressive and permanent, neurologic deficit. So,
and just so everyone knows what these permanent neurologic deficit, we're talking loss of control of, depending on the level, bowel or bladder, so your ability to go to the bathroom, muscle, complete paralysis, right, depending on where the nerves are going. And we're talking big things, sensation loss, and this is permanent. So these myelopathy cases that he's talking about are really severe cases that we need to act on quickly, and that the collaboration there is key.
Yeah.
Give me another one. Another collaboratory that you, maybe post-operative, like the ones that, like, I'm so glad that therapist or that other provider reached back out to me after the surgery. Yeah.
So many cases of what you're talking about, which is, I just saw this patient, they said, they're not supposed to really do anything with therapy. Is that the case? And we can quickly, do a 180 and say, no, that's not the case at all. Let's get them started. So many of those. And, post-operatively, I'm trying to remember the last time, let's say somebody was doing really well for a couple months and then has a setback. And the question is that setback something to worry about or not? And those are great questions. And I love when the therapists reach out to say that, because it's, maybe we need to get some more imaging to confirm everything looks okay from surgery and nothing has changed or is kind of going the wrong direction.
Yeah. I think a good rule of thumb, especially for any therapists or any providers that are seeing patients after surgery, if their symptoms are not progressing in a normal fashion, if things are getting worse or things are not getting better, that is a dang good reason to reach out to the provider that did the surgery. And every majority of the ones that I've worked with are extremely appreciative when we have that collaboration, because 80% of cases don't really need a lot of back and forth, don't even need that communication, because they're going to go well. But there's 15 to 20% of cases like, we need to touch base about this. There's something off, or we need to be on the same page. You have a certain lens, I have a certain lens, and when we come together, we really expedite the healing for this patient. So any other feedback for providers should
I couldn't agree
communicate
more.
more?
That's my favorite part of this job is collaborating with other providers, and for exactly that reason, because I think we can give patients the best outcome. I think, and just like what you mentioned, because of the nature of what we do, I have 10 to 15 minutes with a patient, and it's mostly sitting and talking, and we do some exam, but you guys have a better lens and are doing something totally different than what we're doing with them in the office. And so I think having that comprehensive or complete picture of the patient gives physical therapists, often, either a much bigger or just a different side of the story that we don't necessarily always see. And so, I think it provides, a huge bit of information for us that really helps many times. Yeah.
Before we jump into kind of some myth busters here, just to kind of abolish a few myths and give some more insight into it, are there any other minimally invasive procedures that you do that the public should know about that are really helpful?
Well, yeah. Patients ask all the time, like, am I a candidate for minimally invasive surgery? And the truth is, like, basically everyone's a candidate. It's really just a technique, right? So it's not, we do all the same things that you hear about patients getting spine surgery for. We're just using smaller ways and technology to get there, right? So we do everything from one level microdiscectomies to multi-level problems, but we're just using smaller incisions to get there. So that's it. I mean, we're all doing all the same things.
Yeah. And I love earlier how you said, if especially if you're uneasy about the current recommendation that you got from one surgery, doesn't mean you can't go get another opinion. Just like you're to have a plumber come to your house, or a contractor, or someone working on your yard, you're probably going to get 2 or 3 opinions. And if I've got a lot of different bids on a cement driveway I want to do in my backyard on the side of my house, and I've had 3 people come over and give me very, very different opinions, very, very different execution processes of how they're going to do the job, and very different prices. And they've ranged so much. But by getting 3 opinions, it really gave me a full picture of what I really wanted and confidence in the certain people. I'd get one as like, I could see how they're lacking competence in this specific area, the last guy.
Right.
And then this guy helped me develop more confidence in this guy. And then I learned to ask the right questions. That was really key for me, because it helps you gain understanding and education as you work with multiple people. And I think everyone's kind of open to that. Like, it's okay to get different opinions.
100%.
Like, are you offended when someone says, I want to go get another eye on this?
No, and I offer it. I think, the way I treat patients is how I would treat my family. Like, if you had a family member going for spine surgery, I would have them see 3 different people and make sure at least a couple of those lined up, or exactly what you're saying, evaluate different aspects of each of those different approaches and kind of find the right approach for you based on who you're most comfortable with and the approach that you're most comfortable with. And I think the only way to do that is to get multiple opinions. So
yeah. And there's one piece I'd add, and I'd love for you to add more to this, but I think it's really important that it feels right to you. Like, it feels right in your heart, it feels right in your gut. I think those 2 things are telling you something. And then also it logically makes sense. If it's logically making sense, you're feeling good in your heart about what's going on, and you feel good in your gut, then I think that's you hit a slam dunk. But there's nothing that helps more solidify that you're making the right decision when you get multiple opinions.
Couldn't agree more. Yeah, I think you really want to have that feeling. I mean, so much of, for better or for worse, so much of surgical outcomes are also mental. And I think you want to feel like you're doing the right thing with the right person. And I think that goes a long way in your recovery.
Yeah, what education do you give to patients to help differentiate between nervousness and like their stress versus like, I feel good about this?
Yeah, I think, I try to do exactly what you said, which is really, you want everything to line up like we talked about before, right? You want this to be a logical solution. And for me too, spine surgery is not easy, right? Which is part of why I love it. It's not, one size fits all for the same exact problem over and over and over. So you may have an L4-5 problem, you may have an L5S1 problem. Your MRI shows problems at both levels. Which of these is really causing your symptoms? And I think for me, that's the most fun part of this thing is figuring out this mystery or this puzzle and explaining that and teaching patients about it. And so I think exactly what you're saying is I think the more things line up, both for the surgeon and for the patient, the more comfort I feel and the more comfort the patient feels. Because if we can walk a logical linear path to say, okay, here's the symptoms you're feeling. This is why you're feeling them. I'll show you your picture to show you why you're feeling them. And you've done all the things short of surgery that we typically would recommend for this, and for whatever reason they're not working for you, but everything else lines up, then if we go do this one thing, it should help your symptoms. And I think, walking through that process and taking the time to talk through that process, I think is huge for patients' comfort rather than just walking in the room and saying, all right, here's what you're getting, and so.
Yep. And I think one thing that adds peace to all this is you've done the steps, the conservative things, you've exhausted your efforts in other areas. You've done injections, you've done maybe an ablation, like these other procedures that can lead up. There's a sequential order in which you can do things. Once you're to surgery and you've done all the other stuff, you can be certain that you've made the right decision.
Right.
Like you've done all your due diligence. That said, if you skip all this conservative stuff and you're like, that's not going to work for me because it didn't work for my dad, it didn't work for my neighbor, all the above, and then you get the surgery, and for some reason the 2% cases that go wrong, you might regret not doing the conservative, right?
Absolutely.
But if you do all the conservative and you do the surgery, you're in a good spot.
Yep.
Yeah.
So,
all right, we got some rapid fire questions for you.
Let's do rapid fire. I'm excited.
My goal, or the goal here, is to answer this in 20 to 30 seconds.
Okay.
And I know that's sometimes challenging because it depends, right? But we'll do our best with this. So the first question is surgery always the last resort?
No, I would say most often I'd leave it to the last resort. But if you have like a neurologic deficit or something progressive, we worry about, that becoming permanent, like we talked about before. Those are the cases when I would say surgery is maybe sooner than later on the kind of treatment pathway.
Love it. If you have back pain, or if I have back pain, I'll probably need surgery.
No, mostly false. I would say, the 99% of people with back pain don't need surgery.
Tell me more.
Yeah, as we talked about before, most humans are going to have back pain at some point in their lives, and the vast majority of those cases are improved with conservative treatment like therapy.
Love it. Minimally invasive surgery equals minor surgery.
No, not all the time. I think, again, we're doing, a lot of the times we're doing the same thing with these smaller techniques. So even though, we call it minimally invasive, which means we're getting there through smaller incisions and with technology and this fun technology and fun equipment, it doesn't necessarily mean the surgery itself is minimally invasive.
Love it. Back surgery didn't work for my neighbor, therefore it's not going to work for me.
Yeah, false, kind of what we talked about. Yeah, so spine surgery is not spine surgery, it's not spine surgery, right? So it depends. You want to have a logic to this, and you want to say, okay, what's my problem, and how are we going to fix it? And you want it all to line up.
And then the last one, favorites. What's your favorite spine myth that you have heard at like a dinner, or you see all the time? That's the last one here.
I think if you have spine surgery once, you're going to have it for the rest of your, you're going to have surgery after surgery after surgery for the rest of your life. And I would say, the number of patients I've done one surgery on incredibly outweighs the number of patients that have needed anything, a second or any further surgeries after that. So, the vast majority of patients need one thing. And again, I think that's part of the minimally invasive design and approach is we're going to treat one problem, and
this isn't going to lead to 12 other surgeries.
It's not going to lead to 12 other surgeries because we're not going to cause a ton of collateral damage.
If, I hope, the listeners, as you're listening to this has been helpful for you. And I hope you share it with people in your circle, because this information is critical to understand and can really change spine care forever. Minimally invasive surgeries are so freaking cool. And the goal is to fix the problem and be done with the problem, not have 12 more problems. And we've learned through these traditional measures of surgical intervention, it's leading to other surgeries. And people are getting more and more surgeries from them. But with this new model, we're going in and adjusting these small little things that are causing huge symptoms and fixing the problem and not having multiple surgeries after it. So I hope you have enjoyed this. I want to kind of just ask this last question as we wrap up. Just tell us one story of a patient that really reminds you of why you do what you do.
Oh, that's a good question. Actually, just this past weekend, I had a patient really nice lady who, when I saw her in clinic, had been going for years, probably a little too long, and she would admit this, that she really wanted to avoid surgery. So years and years and years of conservative measures and just kind of giving up hope and not being able to walk. She said she wasn't able to walk more than a block for the last 5 years. And I called her. We did surgery on Friday, just a one-level decompression. She had very significant stenosis or narrowing of the nerves at one level, causing her to not be able to walk. And we did a one-level, minimally invasive decompression and 30, 45-minute thing. She's home the same day. And I called her over the weekend, and she was in tears and so joyful because it was the first time she was able to walk in, she told me, 5 years. And she went to her grandson's graduation, which she was really thinking she wasn't going to be able to make it at and stand at. So it's those kinds of stories that, remind me why I love what I do and why I do what I do and why I get to work with awesome people like you to kind of, through this team approach, take care of patients. And it's what keeps us going.
I love it. The patients are really why we do what we do. We give people their lives back, and it's so cool to be able to work at the level. I can't imagine going in 45 minutes just solving these problems. It's got to be such a cool experience. And keep in mind, this 45 minutes is thousands of hours of practice. Just the level of skill, the level of effort, the level of work that you've had to do to master that skill, to be able to go in 45 minutes, just so much respect.
Well, right back at you. I mean, you guys do the same thing in 45 minutes. So with thousands of hours of practice and expertise. So I think
not as quick, but
equally miraculous, I think.
But I appreciate that. Well, Dr. Steinhaus, it's been such a pleasure to have this conversation. Appreciate what you do.
Yeah, you too.
And what you're doing for the community. Thank you for joining us.
Thanks for having me.